Good evening and welcome to this presentation. This is going to be our pain management department of the Royal Berkshire Hospital, and we are at the Townlands Hospital in Henley. We've been invited by the Henley Patient Participation Group to talk to them and to the members within the Henley on Thames about the various options and treatment options that are available in the Royal Berkshire Pain Clinic. And to take this presentation forward, we've got 4 speakers, my colleagues, Dr. Al Shater, my physiotherapy colleague Renato Silva, and my clinical nurse specialist Kaylee Sloman, all coming and giving and talking to all of you about what to expect in terms of pain management at the Royal Berkshire, and more importantly what the research is telling us about various chronic pain conditions, acute pain conditions, and I will be specifically also doing a small talk about fibromyalgia. Thank you. So my talk for this evening is going to be probably talking about fibromyalgia. That's been my kind of pet interest since the time I joined as a consultant in 2010. And there are some reasons, because I was having patients to look after when I was an anesthetist. I still am an anesthetist. And since I joined the RBH in 2010, it's been a group of patients who have been increasing in number there. How many of you are familiar with the condition fibromyalgia? Reasonable numbers. And how many of you have got any relatives or any members or friends who have the diagnosis? Okay, fair few numbers there. And my hope here is to, in the next 20-25 minutes, is to draw on actually using fibromyalgia as a kind of test diagnosis to illustrate to you how much has changed in how we understand pain management, and hopefully it will make clear to you why Renato and Husham and Kaylee's talks make so much sense, because we need to think about pain management in a very different way. As doctors, we've been taught something different for about 400 years, which is being slowly shattered, but surely shattered. And a lot of what we do in every specialty, in every condition that you have, in every diagnosis that you all carry when you go and see a hospital, we need to think just that little bit differently on what it is that we are after and what is being achieved. And in terms of that, there is a move actually is to choose wisely, to actually ask your doctor what it is that you're after, what is your expectation, and what is their expectation of what it is. And by doctor, I don't mean just GP, every specialist, every healthcare professional that you work with and work for and help with. So we'll start off with an initial tale. And this is to illustrate to you. This came out and this was published in a journal in 1995, quite old there. So this is the story of a 21-year-old builder who kind of fancied that he was invincible, decided to just jump down from a 15-meter height, and found himself having not a good argument with a nail, a rather large nail that went right through. He was in agony when he came to the emergency department. You can imagine what this is. Yeah? Agony, just shouting out. He just wouldn't move. The whole leg wasn't there. He wouldn't really move it at all. He was shouting for anything. We had to give him, rather we, not we, the particular authors in that article, had to give him fentanyl, had to give him morphine, had to give him midazolam, which was a sedative agent. And they decided, well, we have to take him to theatre to get this out, because this is a problem. We don't even know what's happened. And then they decided, let's go to theatre. Let's pull it out from below. He was just screaming and they had to sedate him out completely. Pulled out the boot, and guess what was there? The nail had gone between his first and second toe. Not a scratch on him. But he was in pain. Nobody denied that he was not in pain. He was in full-on pain. And that's the realization that throughout the last 30-40 years, we've always seen patients wherein somehow the picture doesn't match with what they feel. There is that disconnect sometimes between what you're actually seeing. How many of you have had MRIs or scans wherein nothing gets shown? but the symptom, that the feeling, that the emotion that you had was as real as it could get. And that is important to understand, because what you feel is very real. It is happening, it is processed, it is very much part of what's changing in the nerves. But the perception is entirely different. And this has been even published in there. And this is all coming down to the fact, this gentleman on the right, anybody know him? Now, he's a little older than that. This gentleman didn't do much for medicine, but he shaped medicine. He's actually a philosopher, René Descartes. He was a French philosopher, and he lived in the 1500s. And as a philosopher in those times who tried to dabble into medicine, he suggested that pain was something that always started there where you felt it, and it went along there, and it reached that part in the back of the brain in one spot called the pineal gland. And he said that as long as we can find that part of the body where the pain starts from and eliminate it, it will go away. He proposed, and that stood, that the mind, what we think, and the body, what it is entirely different. They are two separate things, and never the twain shall meet. The mind-body dualism was then started then, and even now 500 years later, that still is the model in which I grew up in which all your doctors grew up in which every medical professional and healthcare professional gets taught, that if you have a focus of pain and you remove that, it will be sorted and there will be no pain and everything will be fine. But the realization is that when you have conditions like phantom limb, how do you explain that? Why is a phantom limb painful? How can that be possible if the pineal gland is where everything stops? Once the arm is not there, why should you have a sensation? Why should you have pain? And therein comes the thing. Fibromyalgia is one such condition wherein, for those of you who had relatives who have it, you may have had the situation where you have scan after scan. You'll have MRI scans of your knee, of your shoulder, of your hip, of your back, but it will all come back as relatively normal. Your blood test will be done, it will come back as relatively normal. And what we have realized, and what I've realized in looking after patients with fibromyalgia, is to rethink it entirely differently. The conversation needs to be as there. Nothing in biology makes sense except when you look at it in the light of evolution. And you've got to look at pain fundamentally as what did it mean as a human species for us to survive in this world and negotiate with all the dangers, all the things. Because before we were all comfortable and never had to worry about food and I certainly was a generation which didn't have to, but some of you have gone through really tough times. You've realized that actually each of your experiences matter. They inform what your next experience is. If you can know what you want to do now, it's because you've understood and learned from the past or from your parents or from your childhood, because this is how it's done. And when you go back 200 years, pain fundamentally stood to protect you. It was a system that was wired to make sure that you survived, that you procreated, and you carried on. The internet really wasn't what it was for. Yeah, and that's something to remember, because when you look at fibromyalgia and you think about this was a poem written by one of the patients I got it from the internet there, but it makes it very clear. These are the fundamental symptoms there. This thorn in my flesh, how can I explain? I get up every morning though my whole body is in pain, and that really is one of the things. Severe, unremitting pain that is generalized and throughout the body. Look at the second point there. Get worse from the heat till about September. My brain is in a fog. Words that I can't remember. Concentration problems, memory issues, what patients call as a fibro fog. What sometimes is seen in Alzheimer's and other dementia-like conditions as a fog-like situation. What people get when drugs are, when gabapentin goes in excess, the fog-like situation. They go through that all the time. The energy is being sucked out. Weakness never goes. Nerves feel inflamed from the head down to the toes, and that's the fatigue. That is excessive, unremitting fatigue that lasts and carries on. And spasms in my back, the breathing isn't right, my bed feels like nails. Sleep loss. These are the 4 characteristic symptoms which every fibromyalgic will commit on, and this is what their characteristic is when you're diagnosing, when I'm diagnosing them, when rheumatologists make the diagnosis, when GPs make the diagnosis. And a lot of you will start to see that some of these symptoms overlap with what you feel on some of your bad days. They're not actually unique to the condition, but they are indicative that there is something else happening in this condition. And realistically, if I were to illustrate this with a story there, I probably will see if somebody can guess this. Steffi is not unlike many of my patients that I have had over time, but Steffi is a slightly different person, and I'll let you guess who she is. So Steffi is in her 30s, and she's got fibromyalgia, and her problem started out, and if you look back and peel back, and it's important when you look at evolution, you look at the human being as an organism, as a species. She grew up in a good household. She had nice parents, but her father lost his sister when she was 8 years of age. He couldn't get over that, and he took to drink. His drink meant that he came home more angrier than usual and took it out on Steffi. Steffi, although a bright child, started to become more self-conscious, quieter, but she carried on. Her mom was supportive, but not enough. But she just turned into that awkward child in her 10 or 12, and by 15 she'd put on a bit more weight. She was getting anxious at school, she's getting a bit chubbier, she got bullied. That made her worse off, depression started coming in, she stopped going to school. But she was extremely talented. She kept her talent, she did what she was really good at, and she kept going good till she got an opportunity to go to the school of her choice in the talent that she wanted there. And she started to blossom, she started to become better, she started to prosper there, she was doing really well. And then she got sexually abused at the age of 20 by her mentor. That she never took over. That just stopped. She had to go into therapy. She was diagnosed with PTSD. That for the next 18 months. It was therapy after therapy to just get over that. She then got over that. She started to work back, got back into the profession that she was in. She became famous. She became world famous. I hope all of you should know her. But then her symptoms got to her. Every time she started to get a bit stressed, every time the deadlines were not met, the pain started coming back. The pain was widespread. The pain was unremitting. There was fatigue. She couldn't sleep well. She couldn't focus well. She had to take to some amount of drugs to keep her focus going, her concentration going, and the performance. And then she couldn't hack it anymore. She had to cancel her world tour. Any idea who I'm talking about? This is the story of Stephanie Germanotta, Lady Gaga. A Star is Born. This is her story. And she has a diagnosis of fibromyalgia, which made it all very popular in the papers a while ago. Kirsty Ward, am I getting the right wrong? Desert Island Discs. Kirsty Young got the diagnosis there. I don't know what her background is, but the reality now is that fibromyalgia is a condition wherein the nervous system as a whole can get fired up, can get sensitive, can get oversensitive, and that means that it has gone into a protection mode. The pain that they feel is a consequence of their whole body needing to protect it against further extinction, against the threat of life. That is the concept. They're not under a threat of life, but that's the brain that needs to do what it can to protect that particular person. And it can go there. And now we've seen, when I see, so this is one kind of evolution where I see the diagnosis of fibromyalgia in the 30s. They come to me saying, yes, I've got pain everywhere. But actually, when I scratch beneath the surface, you find that it starts from that bit of adversity in childhood and comes on. It's the culmination of various things that happen. And I see fibromyalgia diagnosed in patients in all of this. You might have a road traffic accident, that's very simple. But then that is enough. Imagine the pressure when you've been sitting in a car and you are going along happily, or just stopped at a roundabout, and in a flash of a moment, without you knowing, you get banged in the back. That is a significant threat to you, because you do not know when the next one's going to come along. Next time you sit in a car, you are going to be fearful. You are going to look a little bit more frequently at your rearview mirror. And if you are more resilient, you'll say, yeah, fine, it happens once in a blue moon. But that is still a threat, and some people and some patients will be wired to be more aware, to be more heightened, to be alert, and that brings on there. It can happen after a serious illness. So I've had patients who've had a significant major cancer diagnosis, and then their fatigue comes on. It may be chemotherapy related, but it can be that as well, that the system just goes into a fearful, because the next time they see somebody on a scan, or some radiologist or someone says, I see something on a scan, that's enough to drive them. That's enough to drive the entire anxiety, the stress, and the system, and then the system goes there. Because I will come to one other part there, and that's what we realized. 25 to 30% of patients who have an inflammatory condition like rheumatoid arthritis, psoriatic arthritis, Crohn's disease, ulcerative colitis, heart failure, chronic back pain, after a period of time, because of the constant stress and the worry or the depression, will end up having symptoms of fibromyalgia. So it is becoming a catch-all diagnosis wherein a lot of patients are coming to the clinic, and it's important that you understand where this is coming from. This is not a unique condition in itself. This is to a certain extent your brain's overprotective nature just to keep you safe. It's not harmful in itself, but it is not helpful. And that is, it gives you the potential opportunity to change things, a lot of self-management, as Husham has said, but it also means there are things that we can help you do, but you've got to first step on to the fact that this is not a pain like René Descartes has proposed. It's not something that's going to be seen on a scan and one injection or one tablet is going to take it away. It's a different ball game altogether. Because this bottom-up formula that we all get taught in medical school, that everybody says if it's something that can be removed, operated, treated, cut out, then it shouldn't be there anymore, doesn't exist. When you go for a surgery, probably at the most an appendix, or at the most maybe a lipoma. But otherwise, I've had pain come on after hernia repair. I've had people come to me after pain after back surgery, after cesarean section, after knee replacements, and they say, why should I be in pain? I've got a brand new knee. Why am I in pain? But the reality is that the mind and the body are never separate. The mind and body are intricately connected, and it doesn't explain this chronic pain. This bottom-up setup that we've been taught for the last 500 years in medical school is a fundamentally flawed model, because it doesn't really explain why 20 million of our population in the UK have chronic pain, and 25% of the worldwide. So in the US, 100 million people have chronic pain, which is why they've had a morphine crisis. In the Europe, 25% of the population in Europe have chronic pain, and this is pretty much across the board, across the world. You are talking about a quarter, 1/5 to a quarter of the population having pain. But every time if you go behind one structure and chase behind one needle and one tablet, you're pretty much going to meet with failure. Fibromyalgia as well, there are 3 million people. There are more people with fibromyalgia in the UK right now than diabetics and cardiovascular heart attacks. But it's not as sexy. People don't die of fibromyalgia. So it's not that popular. So realistically, where we go from, and that's where the deep voice is important. You know what I mean by the deep voice? I'll let this guy explain it.
All right, next up, you want to star in a national TV commercial.
If you're like me, you suffer from chronic back pain.
Uh-oh, back pain.
And chronic neck pain.
Uh-oh, neck pain.
Or the occasional wrist pain.
Uh-oh, one of those parasites that swims up your crank and starts eating away in there.
What? No, I don't have one of those, just the wrist thing.
No, it's in there. Did you go swimming last week?
Yes?
Did you pee in the river?
Yes?
You got one.
Oh my god! Oh my god!
I'm just kidding. It's only your wrist.
What? You suck! You're supposed to use your deep voice for good, not evil. You suck, man!
By that deep voice, I was meaning most of our healthcare professionals. Well-meaning we are, but when you hear, oh, I think you've got a crumbling disc. Oh, I think you've got a joint that's not right at all. Or I think you've got bone on bone that's scratching itself. Or I think this is really dangerous. This is not right. We are well-meaning in the way we want to tell patients something, but sometimes we end up frightening them. The physio, the osteopath, the chiropractor, the GP, the specialist that you see there, sometimes the statements that we give are really not helpful, because that drives up. Because when we say an innocent statement, what your brain actually is doing is building a picture. A crumbling disc may just be a word to me, but you have right now imagined a crumbling disc, because you've now likened it to the last thing that was crumbling, which is a building. And you'll think, okay, that's what happens to my disc, so it's going to crumble, I'm going to be in back pain forever, I shouldn't move, I should just stay still. We know that's not right. In fibromyalgics who get told that when they're already having other issues, that is really not the right message. The deep voice in this case has to be taken with a pinch of salt. To do your homework, to ask your specialist, to actually choose wisely what it is that you want, because the deep voice isn't right every time anymore. Because what do we know from research? The last 15 years has been fantastic in terms of understanding why somebody is in pain, and that explains fibromyalgia as well. The pain is incredibly complex. It's not that easy anymore. It's not one structure, one surgery, one cut of a nerve, or one thing of removed and it will gone away forever. It doesn't. Everything works because it's an alarm system. It's a prediction monster. Every time you have something, it predicts what's the next thing going to be, because you know what the last one is going to be, because what your friend has told you, what you had in your childhood, what your mother and father said when this happened, that's what's going to drive the next decision for you when you have another pain that's coming on. You're not going to be thinking this is the only reason. Pain is very real. We still know it. It is. The builder didn't have a false pain. He wasn't making it up. There was a real pain for him till he saw what it was. And it's felt everywhere in the brain. So it's not just that one area. What do I mean by everywhere? This was the MRI scans that's been done in Oxford recently. I mean, this was done for fibromyalgia patients, or you do it for any other patients there with pain. This is a cut section, slices of the brain. These are all the names of the fancy brain areas there. All of them light up. Pain is such a protective, hardwired system that every part of your brain feels it. Every part of your brain receives the signal, and the brain decides, you know what, this is what happened the last time, I might as well just protect you. And how do we know that? These are all the names. Can you see this? So for example, there's a part of the brain in the front here called the prefrontal area. That area is responsible for how you think, whether you have empathy, whether you have intuition in what's right or wrong, whether you have executive function, the right decision, what dress do I wear, what clothes do I wear, am I being kind, am I being honest? But that area also determines what pain is. The posterior parietal lobe, that's the part in the side over here with a stroke that gets affected. That's responsible for how you hear, how you think, what you see. It's also responsible for pain. So the networks talk to each other. The nerves that are there are going to talk to each other. If pain is going to reach up to there, it's going to affect how you see. It's going to affect how you hear. And that might not be relevant for some of you, but it might be relevant for others. And I've seen patients who can describe their pain in vivid colors. And they hear different things when it happens. The grinding, the noises that they describe are likened to that. This is the most important, amygdala. This is the part in the back of your brain there, which is responsible for fear, for crying, for your heart rate, for your breathing, for emotion. It's also the most important center for pain. And it's important because when you understand that, you can realize why when you're in pain, your breathing goes up, your heart rate shoots up. But it also gives you the potential for thinking in the back there, why does yoga work? Why does meditation work? Because that calms that part of the brain down. When you calm your breathing and your heart rate down, and you can do that, you're automatically going to influence some of the pain nerves in that area there. Because the next step is there. These are the hippocampus. That's responsible for storing all your memories, but it's also responsible for storing the pain memories. This part there, the frontal cortex, that here, it's responsible for emotional attachment, to decide understanding. That's also for pain. So pain is in every part of your body that we think is responsible for you being the person you are, the human consciousness. The pain is attributed, modulated, transformed, changed in that area. It gives you a potential opportunity and power that if you influence all of that, you will influence your pain as well, which is where Renato's talk about all that psychology bit comes in, because we've got the definitive evidence with scans now that it makes a difference, and you can make a difference yourself. It doesn't have to be the surgeon or somebody who's cutting some things out or a needle master there. And this is where is a fundamental thing. When your arthritis flares up and you've got a inflammation in your bowel, in your irritable bowel, in your heart attack, in your headache, in your migraine, that signal that travels from there and reaches the brain is what we call nociception. Pain and nociception are not the same. Nociception will keep occurring every time. Every time nociception will keep occurring. The brain decides when it has to be pain. When it decides it needs to protect you, it will make pain happen. Otherwise, it will be a signal. When you talked about an athlete who can go with a fracture and finish his game, when you talked about soldiers who are supposedly on adrenaline, what we now realize is that when soldiers who have got their limbs broken off, and it's not adrenaline alone, it's the fact that at that point of time the brain decides survival is important, get the job done, the pain can be controlled, nociception may arrive, but I will choose to keep nociception down till I'm safe, and then we can think about pain. You think about that, you reframe the whole concept of pain from a protection system, you will see that it gives you the opportunity to do a lot more, and you will see that it changes how you do. And I've told you, when all those signals of nerves and pain signals throughout the brain come along, it's because of this phenomenon that we've now discovered. Nerves that fire together, wire together. Because if every time you feel anxious and you're in pain, after some time you don't, if every time you had a heart attack, the first time you had a heart attack, you're going to feel anxious. That network fires. The next time you don't have to have a heart attack. If you feel anxious, you can have chest pain. And the more it happens there, your chest pain will keep coming, your heart will be fine, your ECG will be normal, the blood results will not be raised, but you'll have these false symptoms there. We see that with back pain as well. You have back pain all the time there, the scans will say be fine, the physio will be all right, the back pain will be there, but nothing will change. It's because these nerves and the networks have fired and wired together. You can undo them, but undoing them doesn't happen with an injection and a drug. It also has to work with you, how you think about it at that point of time. That is the bigger picture in undoing the wrong wiring and the wrong firing. Because once it happens, it's there to protect you. When you come back to fibromyalgia there, and I look after my patients with fibromyalgia, over the years, these are kind of the 7 strategies I work on. It's not just the drugs and the injections. Yes, I do have a few drugs and injections I give for them, like any other pain condition. But my biggest focus is actually these things. If I can influence their diet, a lot of times patients, and this applies to actually most chronic pain, this applies to a lot of dietary changes right now. The focus on all of you, whether you're heart patients, whether you're respiratory patients, whether you're obese and weight loss is a challenge there, the aim is to look at an anti-inflammatory diet. To look at preferably a low carbohydrate, anti-inflammatory diet, free from processed foods, reduce sugar, low gluten plus minus. That is the way we are all going there. That is what I suggest to my fibro patients as well, and you can get a good outcome from there, but it's 6 to 8 weeks and you have to stick on to that. Sleep, the research is overwhelming that it's 6 to 8 hours is what's required. We don't get that much. Some of you may be the 5-hour awesome guys like Margaret Thatcher, but realistically she got Alzheimer's. Okay. And that's a problem. They found out that people who do survive on 5 or 6 hours or less, they are prone for some of the neurons dying off. Because if you've got to again ask as human beings, everybody is going back in every field, in commerce, in medicine, in literature, in economics, in theories there, we're going back to evolution. We're looking at what was there. Why should humans have 8 hours of sleep if it does not fundamentally and evolutionarily achieve something? And the reality is, with all these artificial lights, we've given ourselves less than 8 hours. But 200 years ago, when light was not an essential there, we got that hours of sleep. That's because during that 8 hours of time is when the brain did its reprocessing. It looked at the memories, it looked at the painful memories, decided which one to archive, which one to not archive, which of them we go, prayed and done. And all of that's important because that gets affected when you sleep less than that. Exercise makes a big difference in how the neurons fire together and wiring together. That's what's important. And in fibromyalgia, especially with the deconditioning that they will have in their muscles, we do encourage them to get there. All this graded exercise, whether it's chronic fatigue or ME or fibromyalgia, I don't bother about graded exercise. What I actually say is that just see if you can get out, get some good fresh air and get some walk done. Even if it's not fresh air, at least in the gym, walking around in your room, walking around in your house, get that period of time done, and that applies across the board to everyone. Education is important. The mind-body dualism, I told you the reason why therapies like yoga, Pilates, CBT, all of that make a difference because you're going after the bigger picture, and the bigger picture makes a difference. Whichever condition you have, it does not matter. Fibromyalgia is a test case, but every other condition that you have, I would urge you to explore these therapies, because if you can bring down those aspects down, a lot of the discomfort and the stress can be brought down. When it comes down to interventions, I do. For fibromyalgia, I do tender point injections, I do lidocaine infusions. We are the only hospital in the whole Thames Valley which does these treatments there. The waiting lists are high. It does work for a lot of fibromyalgics, but we don't insist that this is the only thing that you're going to have every 4 months and carry on, because if they don't put the other things in place, we can't keep offering this indefinitely. This is not a crutch that you can depend on. This is an enabler. This is something to enable you to get to do the next step to reduce it there. Medication, everybody comes on to there, and I think I am with all of you in this point there. Medications have a role to play. But if you think about interventions, I apologize that this slide isn't very clear there, but what it's actually showing is that all these are studies that were done on people who have no pain. But when they did scans of their knees or hips, shoulders, neck, back, ankle, all of them had abnormalities. All of them had tears, disc bulges, arthritis in each of these joints, but none of them were in pain. Nociception and pain are not the same. They all have signals there that should in their right be painful, but they are not. These have been studies that have been done on people who are asymptomatic, no symptoms at all. They go and have hip x-rays and MRIs and they have the problem. The reality is that when you do have a pain and you go there to an orthopedic surgeon or to myself and we do a scan, the same thing will come out. But is it really the cause of pain? Probably not. But then if you're going to go and get an injection done, you will feel that yes, it could give you some improvement. Does it cure the problem? Probably not. But was it ever the reason for pain? I don't think that really we can prove that anymore, because that's why for some of you who may have been on the sharp end, one of you was asking about facet joints. That's where we are struggling. Facet joints have run into the same problem there, that when we do MRI scans on people who don't have any back pain, facet joints show arthritis in 60% of people. So the people are coming back and asking us, well, how do you know then that is the reason for pain? And we can't. And so then it becomes a choice about economics. Does somebody want to pay for you to have injection to something that we don't know is the reason for pain? And that's what's happening to arthroscopy and knee keyhole surgery for the knee, keyhole surgery for the shoulder. It's because exactly of this. In this study on the shoulder there, they did the 40 to 70-year-old people. They did about, I think, 1,000 patients. They looked at their thing and they had rotator cuff tears in 30% of people. They didn't have any shoulder pain, but they had a tear in their rotator cuff in 30% of the people. They had thickening bursa. In 70% of the people had bursitis in their shoulder, but no shoulder pain. And they had overall abnormalities in 96% of the people from 40 to 70 years of age had abnormalities that would be called wrong disease. That's why keyhole surgery into the shoulder has become a low priority. They won't pay for it. Keyhole surgery into the knee has become a low priority, they won't pay for it because of evidence like this, where for example knee, 5,397 knees were tested in people who are between 40 years of age to 80 years of age. Arthritis was seen in up to 40% of people. No knee pain, but 40% of people had knee arthritis. Cartilage was defective. Their buffering system was defective in 40% of people. 20% of people, that's 1,000 people, had tears in their meniscus in their knees, but they were not in any pain in their knees. So these are things that we are coming out now. We could be eager and say, let's go in and do a surgery in everyone, but you need to ask that question, does it really solve my problem? Will it take me pain-free? And what else can I do? MRI scans for the back. Look at this number there. 80% of people above the age of 50 are going to have disc degeneration. No back pain. These people have no back pain at all. They got an MRI done. 84% of 80-year-olds and above, or 60% of those above 50, have disc bulges. I guarantee you every one of us in this room has disc bulges. I'm not in any back pain. I've got 4 disc bulges because I thought as a pain doctor I should know what the state of my back is. So I had an MRI done. I have 4 disc bulges at the lower lumbar level. Touch wood, I'm not in pain. I could get into problem tomorrow now that I said it. Okay, but there you go. But that is the thing that we're coming out of research. And how many of you have seen this program? Yes. Yeah, you know the problem there. And that's where with fibromyalgia like things, where treatments there, we have to look out for the power that this has. It takes many shapes. That's an important part. Medications, only 30% of the drug. The research in the last 10 years says only 30% of the painkillers work 30% of the time in 30% of the people. If people have not had benefit from the drugs, this is the reason. So drugs and injections are not the bee's knees in everyone, in every specialty, in every surgery that you have. I've talked only about orthopedics, but the same problem is with gynae surgery, the same problem is with abdominal surgery, the same problem is with urological surgery. It's not only thing there. That is the issue there. And so my last slide is just going to be talk because some of you have asked about it, and I thought I'll take some potluck. Okay? Because day after tomorrow it's going to be legal. I don't know how many of you are going to ask your doctors about it. But the big thing, just to give you a backup, again, choose wisely, know what is actually happening. The papers are full of stuff there, but the reality is that, again, all of us who did medical school did not have a ball of an idea what this was, the endocannabinoid system. Flower power and cannabis was some 70s. Many of you have probably done cannabis in the 70s in the glorious eras. I've done a little bit when I was growing up there, but nothing out there, and it's got such a stigma now. But realistically, there is this awesome system in our body called the endocannabinoid system. This system is the one that's responsible for maintaining balance, for maintaining bringing you back to a sense of equilibrium from wherever you go, whether it's infection, whether it's stress, whether it's illness, whether it's cancer, to bring you back to the middle ground. This system needs to be functioning well. This system was not even known. Only 5% of medical schools in the US right now even talk about it. Only 10% of medical schools in the UK actually started to talk about it. This is not even read in your medical schools, and it's only going to be a few interested GPs and doctors who might have a knowledge about this. But really, it is the next 15-20 years. That's why you'll hear so much. We've jumped on the bandwagon a little too early because we're still looking into the system there, but people have got ahead of themselves. What we know now is that there are these 2 kinds of receptors. One of them is located all over the brain. More than any other molecule and drug that you think of and that acts in the brain, there are more receptors of CB1 throughout the brain, except in the center for heart rate and breathing, which is why cannabis doesn't kill. It doesn't cause any heart attacks. People don't die like morphine or other drugs. You don't have breathing difficulties. Your heart doesn't stop, because these receptors are not there in the heart, in the center for the heart and in the lungs. So breathing is not affected, heart is not affected at the cannabis that you have from the plant. Okay? You have 2 fancy molecules. It's called CBD and THC. THC is the one that gives you the high, the psychoactive one. CBD doesn't do anything. CBD acts on some other receptors, but it acts on the immune system. CB2 is entirely in the immune system. That responds, regulates and changes and modifies and does the orchestra and conductor for your entire immune system. That's the theory right now, which is why you see cannabis in the papers and everybody says let's take it for everything and anything under the sun. That's the reason, because it is the ultimate orchestra conductor for the entire system. There are the plant ones, which is what everybody hearing about. Epidiolex is the one that the epilepsy kid and the mother who got the Caldwell, Billy Caldwell in the papers. That's this particular drug, Epidiolex. Sativex is the whole plant spray that some of you with MS might have heard about. That was the only thing in the country for the last 10 years. In the UK, that's the one that your body produces. We now know that your runner's high that you have or the exercise high that you have is not dopamine. It's actually anandamide. Anandam means pleasure, happiness in the Sanskrit Indian language. That's where it comes from. The synthetic ones are not relevant there for you. But what's the present status? Canada has of October 17th legally and for recreational and medical use legalized it. We, day after tomorrow, we are legalizing it only for medical use, not recreational use as yet. It will follow because 23 states in the US have again made it medically legal, and some of the states like Colorado have made it recreationally legal, but federally it's still illegal. That's like, Berkshire saying it's legal, but Warwickshire saying not legal, or the UK saying no, not legal. That's a kind of thing, but that's the US for you with Trump out there. But this is what is there. And the last part, you just have to understand that there are lots of things going around. Lots of patients keep asking me, fibromyalgia has become a very common thing to ask. There are a lot of other THC. The ratio between the psychoactive and the not so psychoactive component is what decides what you should do. For those of you quietly thinking, should I try it or not? This is my advice. The problem right now is that in the UK, it's a food supplement. It's not been, what's available in the market is a food supplement. There's only one medical cannabis product available, which is Sativex, which is a whole plant. All the others are synthetic ones in the medical side. As a plant-based product, because it's a food supplement, there's no regulation at all. There are 3-4 companies starting from Holland & Barrett to various other online companies. My suggestion is that if you guys want to know, this is another example where you have to choose wisely. Go to one person that some of your friends may have tried or done, speak to them, stick to one supplier from online or Holland & Barrett, start from the lowest dose that that person has said, and just go with that manufacturer, because the problem is right now when these guys are coming out from plants, they're making this, each one of them has got a slightly different species of a plant to pull out the drug from. Each one of them refines it in a different way to bring the product. So realistically, we have no idea whether 100 milligram from one manufacturer or one thing equals 100 milligram of another manufacturer. So stick with one manufacturer, go up on there and see where you land in, see if it helps you. It is supposedly safe. That's what the research seems to say. It's not great research right now, but it is what it is right now, and it's something that for you to think about. It's not something we can prescribe ever. We can only prescribe the medical grade cannabis, but the reality is the medical grade cannabis Sativex is again exceptional circumstance. So when people are not being given permissions for facet joints and these ones here, unless and until you are having a child who's got epilepsy of 15 times or more a day, I don't think any of the specialist doctors can prescribe the fancy things from come November 1st. Whatever the papers may tell you, that's the actual truth locally here. Sorry if I've just run over time. I'm finished.